Yes, sir. Sir.
My talk is about
Sir, was not able to hear you. Can you just repeat?
My talk is 35 to 40 minutes.
Yes, sir.
It's okay, na?
Yeah, I feel that's fine, sir. So we have post-talk, we'll have questions to you also directly. So I think 15-20 minutes for the questions we can keep.
Okay.
Yes, sir.
So we are starting in 3, 2, 1. So we are live now.
Yeah. Dear doctors and dignitaries, a very good afternoon to you all. Hope you and your families are safe in this pandemic. I, Dr. Anil Jaiswal, on behalf of Corona Remedies, welcome you all for today's webinar on preterm labor in association with FOXI. We thank Dr. Alpesh Gandhi for giving us this opportunity to organize today's scientific webinar. Dr. Nilesh Balkhavade will moderate the webinar proceedings. I'll introduce Dr. Balkhavade. Dr. Nilesh Balkhavade is an MS, DNB, MNAMS, FIAG Fellow, Reproductive Medicine, Diploma in Gynecological Endoscopy from Kiel, Germany. He is the clinical head and fertility specialist attached to OSS Fertility, Pune, then joint clinical secretary of POGS in Pune, chairperson-elect FOXI Quiz Committee 2021 to 23, an active member of Managing Committee POGS, and a FOXI worker since last 9 years. He has won numerous awards. He is the winner of West Zone FOXI Usha Krishna Quiz in 2009. He won the Dr. Smitha Jog Award, Best Incoming Managing Committee Member, POGS, and also the Best Paper in Maharashtra Chapter, ISAR 2019. He published several books, amongst which FOXI Focus on Progesterone, Newer Technology in Obstetrics and Gynecology, covering medico-legal aspects, what to do after MD Gynec, FOXI Quiz Book, authored a number of chapters, papers published in national and international journals, and is a faculty in various state, national, and international conferences. I now hand over the proceedings to Dr. Nilesh Balkhavade to introduce our speaker, as well as be the moderator for the proceedings. Dr. Nilesh.
Thank you, Jaiswal sir, for that kind introduction. And I'm humbled and honored today to be a part of this wonderful CME of FOXI along with Core Connect initiative of Corona Remedies. This is a series of CMEs which is taking place, and today we have a CME on preterm labor. And it's my proud privilege to introduce one of my mentors in FOXI. We always say in Sanskrit, Mahajana yeno gataha saha sanmarga. So big people who have traversed those paths, it's just happiness to travel through those paths and to find a life for us. So one of these big peoples is in front of me and in front of all of us, Dr. Ameya Purandare, the speaker for today. He's a consultant obstetrician and gynecologist at Purandare Hospital and KJ Somaiya Medical College and Super Specialty Hospital. He's a consultant at HN Reliance Hospital, Bhatia Hospital, Masina Hospital, Mumbai Police Hospital. He was a joint secretary of FOXI in 2019, and we have seen immense work being done in his tenure. He was the chairperson of Food and Drugs Medical Surgical Equipment Committee of the FOXI in 2015 to 2017. He is the assistant administrator of the FOXI Manyata project and quality care in safe childbirth, member of the managing committee and mentor of the Mumbai Obstetric and Gynecological Society. He was the honorary secretary of the AMOGS, and currently he is the state coordinator of AMOGS from 2020 to 2022. Credentials to his name are many, but I can assure you he has a vast experience in handling his expertise in handling the preterm labor cases, and that's why we have this apt speaker for today's topic. Welcome you, sir.
Thank you so much, Nilesh, for those kind words. At the outset, I would like to congratulate Dr. Alpesh Gandhi, FOXI President, for this very, very unique and important initiative, Core Connect, that he has launched. I would like to thank Dr. Alpesh Gandhi President Foxy, and Dr. Jaideep Tang, Secretary General Foxy, for having given me this opportunity to be a speaker in one of these programs. And also I would like to thank Team Corona Remedies who have initiated this or supported this initiative and have so nicely organized this and will be organizing it in the future. So if I'm allowed, I can begin my presentation. So can I start sharing my screen, Nilesh?
Please, sir. Please do start. So I request the delegates to be kindly attentive for the session, and we have a wonderful quiz based on this today's session. And also they can interact with Ameya sir after his session and ask him questions, to which he will answer. Thank you.
So I have been given the important topic of preterm labor, and I will be covering prediction, prevention, and treatment with respect to preterm labor. We all as obstetricians know that if a baby is born too early or too soon, it is a challenge for not just survival, but long-term consequences and outcomes of this premature child. But as obstetricians, how much ever we try to deny, we do face prematurity and have very little to offer for it. But like Franklin D. Roosevelt, the eminent US president, said, "A smooth sea never made a skillful sailor," and therefore it is a challenge as obstetrician and as a neonatologist to manage a preterm labor as well as a preterm baby. But we must at all times endeavor that every day, every hour that we gain in prolonging the gestational age in preterm labor is worth the wait, because it will significantly improve the baby's outcome unless the intrauterine environment is hostile for its further growth and development. So what is preterm labor? We all know that it is nothing but the onset of uterine contractions of adequate strength and frequency that cause progressive dilatation and effacement of the cervix between 22 and 37 weeks of gestation. Why are we talking about it today? Because it is the leading cause of perinatal morbidity and mortality and affects almost 1/4, that is 23% of pregnancies in developing countries like India. Let me give you some important and vital statistics. These have been put forward by WHO. Preterm birth, by the numbers as they call it, there are 15 million preterm births occurring every year, and this number is just rising. 1.1 million babies die from preterm birth complications. 5 to 18% is the range of preterm births across the 184 countries of the world from where we have data. More than 80% of preterm births occur between 32 to 37 weeks of gestation. And this is, in fact, a positive sign, because most of these babies can now survive with essential newborn care. 75% plus deaths of preterm births can be prevented without intensive care. And 7 countries, with their strong resolve, have half their number of deaths due to preterm birth in the last decade. From what you will see in this chart is that Southern Asia seems to be the most prevalent area or region globally where preterm birth is more prevalent. The next chart is something that we should not be very proud about, because India is not just the diabetes capital of the world, but more importantly, as obstetricians, it is the preterm capital of the world. More than 35 lakh preterm births occur in India annually. Now, why does this occur? If you look from the economist's perspective, there are 2 important hashtags that you must remember. One is population and the second is GDP. The greater the population, the greater the risk of preterm birth. The lesser the GDP, that means more poorer the country or the population, more is the risk of preterm birth. And here you will see India, because of its largest population, ranks first in the prevalence of preterm birth. And this was data in the year 2010. And I'm sure that it must have increased further as we reach 2020. On the other hand, the second map that you see, you will find that the poorer countries, mainly from Africa, with low GDPs, have got higher preterm birth rates as compared to the more westernized countries. Keeping this in mind, WHO said it's time for action. And way back in 2012, they launched the campaign which was called as Born Too Soon. It was a subset of the campaign for the Save the Children initiative. And the reason for this is that WHO identified it as a global problem because 15 million babies are born too soon every year. 1.1 million deaths, mostly in low-income countries, occur. Prevention of preterm births, they said, must be accelerated, and many premature babies can be saved as they identify with now with appropriate care. So let us first understand what causes preterm labor. Sorry to say, but in almost 30% of cases, preterm labor occurs spontaneously without any explained cause. In another 25 to 30%, the culprit is infection or inflammation. 20% is because of an iatrogenic cause, maybe a maternal complication like preeclampsia, diabetes, prior cesarean section, or a fetal cause ranging from IUGR to non-reassuring fetal testing. And in 30% of cases, there is giveaway of the membranes leading to PPROM causing preterm birth. Now, as I told you, preterm birth rate is higher in low-income countries than higher income countries. And what is the link for this? The link is LINC, or lifestyle, infection, nutrition, and contraception, being the broader categories responsible for preterm birth. As far as lifestyle factors are concerned, the ones which have a direct relationship with increased risk of preterm birth include tobacco chewing, alcohol, drugs, diabetes, hypertension, asthma, thyroid disease, depression, and violence. And on the other hand, more the physical activity, excess of it or less of it, can also lead to preterm birth. Infection. The key infections associated with the occurrence of preterm birth are UTI, malaria, especially important in our country, HIV, syphilis, and don't forget bacterial vaginosis, because that is also known to be associated not just with preterm birth, but premature rupture of membranes and even chorioamnionitis. Moving on to nutrition. Maternal nutrition is an essential component for a positive pregnancy outcome, as WHO has put it. Not only it is essential for maternal nutrition affecting pregnancy outcome, but obviously what the mother eats, the baby gets, and therefore fetal nutrition is directly dependent on it. And hence, an underweight mother or an obese mother, anemic mother, and those with dietary deficiencies ranging from folic acid, iron, or other micronutrient deficiencies can lead to preterm birth. Moving on to contraception. Why are we talking about contraception when we are talking about pregnancy? They are directly related. The earlier the age of pregnancy, like in adolescent pregnancies or advanced age, are associated with preterm birth. And more importantly, the lack of spacing between pregnancies is known to be an important factor causing preterm birth. Moving on to after understanding what are the important factors, let us see what actually initiates labor. Labor is initiated as per recent understanding proposed by FIGO as genetic factors, dysfunctional energy metabolism between the mother and the fetus at the mitochondrial and the dietary level, inflammation and infection, maternal or fetal signals that initiate labor, and anatomic changes in the uterus, cervix, or placenta. We are all aware about the role of the stress theory in preterm labor. The stress theory leads to the activation of the maternal fetal adrenal axis, which causes the release of CRH, alters the placental estrogen progesterone ratio, is responsible for the initiation of labor. Infection and inflammation cause a release of cytokines, and there's a fetal inflammatory response syndrome. Ischemia or hemorrhage, thrombin activation is responsible for the cascade leading to labor, and there could be pathological uterine distension causing increased gap junction along with contraction associated proteins and upregulation of prostaglandins and oxytocin receptors. So here you see there is a stress occurring across the materno-fetal interface via the placenta, and that could be eitherwise the fetus triggering off the labor or the mother causing the fetus to go into stress, triggering off the labor. What are the genetic factors which could influence labor? It is said that 30% preterm labor is because of a heritable cause, and therefore the recurrence rate risk may also occur to the extent of 30%. Protein coding genes governing inflammation, gestational age, and the onset of labor have been identified. Mitochondrial genes governing bioenergetics, both related to nutrition and diet, have also been proposed to be associated with the induction of labor. And regulatory genes and networks could, if disturbed, be plausible explanations for intergenerational persistence of socio-demographic disparities. And this is why preterm labor is more common in women who are stressed out, or even with certain races of the world where it is more common. Now, why determine genes affecting preterm birth? The causative coding gene could be a potential therapeutic strategy, including pharmaceutical agents. We all know with the COVID vaccine research that how important genes as well as the microscopic and electron microscopic understanding of organisms are important in therapeutics. And hence, hyperactive ion channel myometrial genes could be inhibited by some wonder drug in the future, which when identified would block the gene, inhibit the gene, and therefore stop the labor. At-risk prediction and aggressive prevention therapy for at-risk cohorts, minimize exposure to deleterious agents for at-risk of cohorts, and after expression of regulatory genes susceptible to stress. So, friends, genes could be one of the next therapeutic interventions which would help us in preventing preterm labor. Today's world is all about organisms, and we are so obsessed with COVID that we don't think about beyond COVID these days. But what is the microbiome? The microbiome is commensal microorganisms living within the human body. They colonize all exposed tissues, oral, respiratory, digestive, and the urogenital is no exception. The human microbiome, friends, consists of almost 1 crore plus genes, and out of which the human genome is 23,000 genes only. So see how big the microbiome is as compared to the human genes. And therefore, they will obviously, when they are inhibiting our bodies, influence how we act, how we work, are we healthy or are we diseased. 10 times more organisms are therefore there than human cells. And therefore, that means there are 10 times more DNA acting. How does this go into clinical practice? This very important study showed that if there is a lack of lactobacillus in the woman's vaginal flora, it influences preterm birth. And this will have important implications because premature labor is a global health problem. And therefore, if we know what is deficient in the flora, we could understand how we can alter it and what outcomes, adverse or positive, we would be able to alter in order to get a positive result. What we must also remember is that shorter the interpregnancy interval, more altered will be the flora and therefore more the chance of preterm birth. The fetal inflammatory response system is an ascending infection which occurs across the vagina from the lower genitourinary tract into the upper reproductive tract, and that causes a fetal tissue response which causes release of prostaglandins on one side, release of cytokines on the other side, and on the third mechanism is that it causes weakening of the membranes and their subsequent rupture, myometrial contractions, cervical ripening, and finally it ends up in the initiation and the progression of labor leading to preterm delivery. So to summarize the causative factors, The final word is that 2/3 of all preterm births are associated with risk factor lacking a known biological basis. And hence, I strongly believe that the etiology is not unifactorial, but multifactorial in most of the cases. But the final pathway is that it all leads to affection of the decidua and the membranes, and their alteration leading to release of protease and prostaglandins, and finally causing cervical change and uterine contractions, leading to the onset of preterm labor. Which infections are responsible for preterm labor? They could be systemic infections like pyrexia or pyelonephritis, distant infections like periodontal infections, which can and have been identified to be associated with a greater risk of preterm labor, and local infections ranging from bacterial vaginosis and chorioamnionitis. Periodontal infections are usually oral gram-negative anaerobic organisms, and they have been identified in women who have gone into preterm labor. The spread is hematogenous and reaches up to the fetoplacental unit. There is a dental exam score. The worse the score, the greater the risk. And at times, antibiotics may not be enough. And hence, we have to emphasize the importance of intimal hygiene, oral hygiene, personal hygiene in reducing the risk of preterm labor. Let's move on to the important aspect of prediction of preterm labor. How great would it be if we could predict which patient is likely to go into preterm labor and ensure that we minimize and completely negate preterm labor from this world. Prediction is based on 4 key principles at the present moment. Assessment of risk factors, vaginal examination to assess cervical status, ultrasound visualization of cervical length and dilatation, which was completely transformed and documented the risk and helped us to define or have designs for in the establishment of risk and the relative risk, and also certain biomarkers which have come up recently and which are now available commercially. And these biomarkers are from the cervicovaginal secretions. The risk factors have been very nicely defined in the NICE guidelines as those which are modifiable and those which are non-modifiable. Modifiable ones include lifestyle patterns like cigarette smoking, drug use, anemia, urinary tract infections, gingival disease, strenuous work environment, lower genital tract infections, which can all be modified by good hygiene and appropriate treatment. Non-modifiable risk factors include prior preterm birth, race, age, poor nutrition, low pre-pregnancy weight, low socioeconomic status, absent prenatal care, cervical injury, uterine anomaly, excessive uterine activity, premature dilatation or effacement, or over-distended uterus, as can be seen in twins, polyhydramnios, and vaginal bleeding both in the first and the second trimester. Now let's go a little bit further and let me explain to you how the preterm births odds ratio has been put forward by this very important study group, the FIGO working group, which had 18 reports and looked at 20 factors. Remember, high individual risk is noted in patients with prior preterm birth, those with preeclampsia and diabetes. But even though there is a high risk, there is a low population prevalence of these. Not all pregnancies are complicated by these, lesser number of them. There is a low risk, but a high population prevalence in those where pregnancies which are affected by maternal age, obesity, less prenatal care, less education, and more poverty. So even though the risk is less, but there is a high population prevalence because a larger part of the world lives in with these adverse socio-demographic factors. Let us look at these 2 charts, and these 2 charts tell us that if there is a prior preterm birth, the risk almost increases by 2.5 times. So if there was no prior preterm birth, then the risk is only 9%, while if there is a prior preterm birth, the risk goes up to 22%. 2 prior preterm births, the risk is as high as 42%. On the other hand, if there has been a term birth followed by a preterm birth, the risk comes to half, 21%. But if there is a preterm birth followed by a term birth, the risk is even lesser, 13%. And if there has been 2 prior term births, the risk is minimal as 5%. And therefore, understanding the prior history of the pregnancy is very important in our assessment and estimation of the risk in the present pregnancy. But the golden rule is more the number of prior preterm births, greater the risk. And if there has been a term birth, it reduces the risk. Vaginal examination. Digital examination is the traditional method used to detect cervical maturation, but quantifying these changes is often difficult. And all that we can say is, I feel the cervix is short and I feel the cervix is soft, but we really can't extrapolate this into actually quantifying these. And there is where ultrasound has made an important change. And in modern practice, the important prediction modalities include TVS for cervical length, fetal fibronectin, and insulin-like growth factor binding protein 1, which is now recently launched as a point-of-care test in estimating the risk of preterm birth. Transvaginal sonography estimates cervical length, and lesser the cervical length, greater the risk. As you will see from this table here, the lesser the cervical length, the greater the risk of preterm birth. And here you will see these 2 calipers tell you the residual cervical length, and you can actually see the funneling of the cervix. That means the internal os is giving way and the cervix is starting to open up, increasing the risk of preterm birth. Please remember an important rule of thumb, which was proposed by IAMS in his IAMS criteria, that the change in the cervix occurs as a continuum. You begin with a T-shaped relationship, then Y with minimal funneling, V with progressive funneling, and finally U with herniation of membranes. Now, if you are trying to understand practically how this is going to be important in assessing the risk for your patient, the rule of the thumb is 2. 1, 24 by 24 rule. That means if the cervix is less than 24 mm before 24 weeks of gestation, the risk of preterm birth is about 24%. And the second is the rule of 50 by 50. That means if the residual length, as you see here, becomes less than 50% and the funneling length becomes more than 50%, then the risk of preterm birth is 50% or more. Now, therefore, how do we develop a protocol in measuring cervical length? When should you measure it and how often? So if there is a singleton pregnancy with no prior preterm birth or no prior twin gestation, you do a single TV examination at around 20 weeks of gestation. And if the cervical length is more than 2.5 centimeters, she can go for routine prenatal care. But if the cervix is short, then you can give her progesterone vaginal suppository throughout the pregnancy up to 36 weeks of gestation. On the other hand, if the cervical length in a patient who has had previous preterm birth is more than 30, you can repeat the measurement every 2 weeks. But if the cervical length is less than 3 centimeters, you need to measure it either weekly, or you may have to put a cervical cerclage stitch or give her hydroxyprogesterone injections, which I will be talking about a little later. So the moral of the story is cervical length beginning from 20 weeks in a low risk patient will identify the risk of cervical shortening. But if there is a patient with previous preterm birth, you need to intervene earlier, either 14 weeks if the previous preterm birth was in early gestation, or from 28 weeks if the previous preterm birth was late in gestation. And we need to start estimating the cervical length as early as 14 or 16 weeks. And the cutoff here is not 2.5 centimeters, but 3 centimeters. And you may have to be more frequent in assessing cervical length in these patients. Moving on to fetal fibronectin testing. It's not routinely used. It's a good predictor for preterm delivery. Can be done after 24 weeks in symptomatic patients up to 34 weeks. And it allows the clinicians to rule out patients at low risk for delivery within the next 2 weeks or fortnight. Fetal fibronectin values quantitatively are called as positive if you detect more than 50 nanograms per ml in cervicovaginal secretions between 24 to 34 weeks. The cervix has to be less than 3 centimeters dilated. The patient should not have had coitus in the last 24 hours, and the membrane should be intact. ACOG says that it has good negative predictive value and puts it as level B in evidence related risk. But they go on to say that fetal fibronectin is not a useful screening test in unselected population because the positive predictive value is only 13 to 36%, and therefore probably it's not commonly clinically used. A newer marker which is being introduced in India now is insulin-like growth factor binding protein 1. It's synthesized in the liver and is involved in fetal growth and development. Decidual cells and liver secrete its phosphorylated isoform. Higher levels correlate with cervical ripening. Amniotic fluid and fetal serum contain non-phosphorylated form of this, which are the targets for certain tests. It's not affected by semen, has a higher negative predictive value than fetal fibronectin in predicting preterm delivery in 48 hours, 7 days, and 14 days. And you have what is called as the actin partus test. It's a visually interpreted qualitative test which is based on immunochromatography. It's like a dipstick test in detecting the presence of this marker in cervical secretions and can be done from 24 to 34 weeks of pregnancy along in patients with symptoms of labor, suggesting the possibility of preterm labor. There are two types of them. One is what is called as the actin prom, where the membranes have given way, and the second is the actin partus, which I just talked about, is the one when the membranes are intact, and you get the results as within 5 minutes and is found to be very, very useful as far as accuracy is concerned. Which are the patients where you can't do these tests? These are the patients in where there are ruptured membranes, the cervix is dilated more than 2 centimeters and is very short, there is vaginal bleeding, there is a coexisting medical disorder like severe preeclampsia, and the gestational age is either less than 24 weeks or more than 35 weeks. In these cases, this test would not be useful. Now, as I told you, you are able to get either a negative test or a positive test. So there is no gray zone in between. So what does the negative test tell you? A negative test has a negative predictive value as high as 100% for birth within 48 hours and 92% for birth within 7 to 14 days. So if the patient has a negative test, most certainly she is not going to go into labor in the next 2 days, and most likely she will not go into labor within the next week or fortnight. If the result therefore is negative, the patient should be discharged and told to go home unless there is some other obstetric indication which mandates her admission. All women with a negative test should be given education on the signs and symptoms of preterm labor and reassured that they can come back at any time. A negative test is not helpful if there is cervical dilatation, and clinical judgment must always be a part of the assessment. On the other hand, once a positive test has been confirmed on a woman who has signs and symptoms of preterm labor, the patient should get steroids immediately. Tocolysis should be considered. NICU should be notified of such an admission, and if there are no cots available, it may be necessary to transfer her to a place where NICU facilities are available, namely carry out an intrauterine transfer. And if the woman has not delivered within 7 days, a further test may be indicated. The other tests which were used in the past but not used now are maternal salivary estriol levels, and other interventions have been the home uterine activity monitoring and bacterial vaginosis screening. All of these have found to be greatly associated in predicting preterm labor, but there is no data to support the use to identify or prevent preterm labor in clinical practice. Let me talk about some recent state-of-the-art study. How are uterine contractions initiated and proceed voluntarily? Where are the uterine pacemakers? You need to locate the pacemakers using the same strategies by which cardiologists locate the foci for cardiac arrhythmias, because aberrant pacemaker activity could be the path to which is responsible for preterm labor. And using electromyometric imaging, what is called as ME, these have been identified, and this technology involves electrical sensing as well as the use of MRI. And here you can see this is the hot zone where the uterine activity is going on and has been localized. This is the pacemaker. This has become irritable. This has become hypersensitive, and that is causing the uterine contractions. Maybe with the advances in imaging and MRI, we will be able to use this technology more fruitfully and commonly in our practice in predicting preterm labor. Now, if we can't really predict preterm labor, can we prevent preterm labor? The SDG goals which link to preterm birth are all of them. And you can see they range from nutrition, education, empowerment, maternal health, infection, environment sustainability, and global partnership. And all of them are directly influencing a better response for preterm delivery or prematurity management. So the prevention strategies could be patient education, risk identification, early diagnosis, prophylactic progesterone caproate, prophylactic antibiotics in bacterial vaginosis, and home self-monitoring of uterine activity with the help of an external tocodynometer. But what we can tell our patients is that you alter your lifestyle if you are at risk. Reduce work, reduce housework and childcare, reduce smoking and stress, reduce travel and commuting, avoid sexual activity, take bed rest at home, avoid hot and humid climate, and improve nutrition, especially if you're a fish eater, have more sea fish because the oils are found to reduce the risk of preterm birth. What about the role of cerclage and progesterone? One surgical, the other medical in prevention of preterm labor. Both of them are facing in the opposite directions, and let us see if which one of them is better and how we can use both of them in managing preterm labor. RCOG put forward in its Green Top guidelines way back in 2011 that women who have had repeated losses or those who have had uterine anomalies or those who have had cervical tears, etc., require, or cervical operations require the placement of a stitch with the help of cervical cerclage. The terminology of cerclage has evolved, and the modern terminology is that it is history indicated if you have a bad history before, ultrasound indicated if the ultrasound tells you that it's a short cervix, and in more advanced cases, on cervical examination, you find that the cervix is well advanced, and in that case, it will be a rescue, emergency, or urgent cerclage. So it could be either a prophylactic cerclage, a therapeutic cerclage, or a rescue cerclage. The common ones that we use are the vaginal procedures, McDonald and Shirodkar, and rarely we may have to make the patient undergo abdominal procedure if vaginal may not be possible or has failed. As far as rescue cerclage is concerned, there are small randomized studies. This is when membranes are bulging. We take an anteroposterior stitch, which is called as the Hefner stitch or the worm stitch. It's a mattress type of stitch, but it is associated with a greater risk of complications in the form of rupture of membranes and chorioamnionitis as compared to elective or urgent cerclage. And in certain cases, one must not be tempted to put the stitch. That is in cases of active preterm labor, chorioamnionitis, bleeding from the vagina, PPROM, fetal distress, fetal anomaly, and fetal death. Next, we move on to the curious case of progesterone. Probably progesterone is the gynecologist's or the obstetrician's favorite hormone. most used hormone. And I must confess, as Nilesh will agree with me, as he is an IVF specialist, the most abused hormone in most cases. Now, why is it called progesterone? Because it prolongs gestation and it favors pregnancy, perhaps. And that's why it is proposed as useful in preterm labor. But what it is responsible is that it quietens the uterus. It tells the uterus to quieten down, to be more, more silent, and therefore less irritable. And its action is at the placenta, amniotic fluid, fetal membranes, at the myometrium and cervix. So all the places or sites where preterm labor is initiated, it has an action which opposes labor and prolongs pregnancy. Which are the progesterone options that we have? The 70 hydroxy progesterone injections, which are to be given in a dose of 250 mg per week, micronized progesterone to be given vaginally, and progesterone gel, which is 8% and has to be given every night. Do we have evidence about its role? Yes, we do have evidence all across the world in different populations with different races and different ethnicities. The European Association of Perinatal Medicine says that all pregnant patients should undergo a transvaginal ultrasound, and asymptomatic patients with a short cervix or who have a twin pregnancy and have, even though they are asymptomatic but merely have a short cervix, should be given progesterone in order to prevent preterm birth and neonatal morbidity. The NICE guidelines say that in those who have had a previous preterm birth or in whom there is a transvaginal sonography as early as 16 weeks showing a short cervix, please discuss the role of prophylactic progesterone and cervical cerclage and take her preferences in account and offer prophylactic progesterone in those who have no history of previous preterm birth or and in those who have got a shorter cervix, which is less than 2.5. Figo went on to say in 2015 that all patients should have a cervical assessment, just like how you have a nuchal translucency scan or an anomaly scan. All pregnant patients, irrespective of their previous history, should have a cervical assessment at around 18 to 24 weeks. And those who have a short cervix should receive micronized progesterone or any form of progesterone which they feel is convenient and cost effective. Recent guidelines have also recommended and have gone one step further and said in those patients who are asymptomatic, who do not have a history, but who have got a short cervix, progesterone could be considered as an alternative to cervical cerclage and could be useful in managing these patients. This has been put forward by RCOG, the American College, as well as the Canadian College, and they talk about daily supplementation with progesterone. To put it simply, singleton pregnancy prior preterm birth, give progesterone. Singleton pregnancy, normal cervical length prior twin preterm birth, give progesterone. Singleton pregnancy, no prior preterm birth but short cervix, give progesterone. And the progesterone which is found to be most useful or studied is hydroxyprogesterone caproate, to be given in an injectable form, 250 mg IM weekly, beginning from 16 to 20th week. And it is now available commercially, both in preparations of 250 and 500 mg. Corona Remedies comes with a very purified form of this progesterone and is quite well accepted by the patients with minimal side effects. In multiple pregnancies without a short cervix, no need to give prophylactic progesterones. But if they have a previous preterm birth, you need to give progesterone. And obviously in those who have got PPROM, there is no role of progesterone. Now, which is better, 17-hydroxy or micronized progesterone? And this debate is answered by this interesting paper first published in 2013. And they said that when they compared both these, and they found that vaginal progesterone was probably more effective for preventing preterm birth and had fewer side effects. These were about 50% of patients, but you will see that it was more than 75% useful in patients who were more than 34 weeks of gestation. And these are the patients probably where the injectable progesterone does much better. And in conclusion, they went on to say that maintenance tocolysis with oral micronized progesterone significantly prolong pregnancy, but they went on to say that it does support the use of micronized progesterone as a maintenance tocolytic for prolonging pregnancy in cases of arrested preterm birth. It was also found to be useful in patients who had received this progesterone in ART pregnancies, that is following ICSI and IVF. And they also compared it with cerclage, and they found that progesterone is an alternative to cervical cerclage in those patients with previous preterm delivery or mid-trimester loss and a short cervix at around 20 to 37 weeks of gestation. Let's look at the economics of this, and you will find that most of the progesterones have good tolerability. The injectable ones can cause local side effects, but all of them achieve high plasma and tissue concentration. Their efficacy is effective in selected population, and most of them are cost effective, especially the tablets, pessaries, and the injection as compared to gel. So progesterone is a yes in preterm birth. Injectable progesterone is also useful and is found to be viable, especially in those at greater risk, and vaginal progesterone can be used as prophylactic in patients who are asymptomatic with a short cervix. Moving on to diagnosis. The three criteria to document preterm labor are uterine contractions, cervical change, cervical dilatation, and effacement. You could combine this with vaginal ultrasound and fetal fibronectin. So if there is a negative fetal fibronectin and a cervical length is more than 3 centimeters, rest assured that it's not preterm labor, and the likelihood of delivering in the next week is less than 1% and can be safely sent home without any further treatment. But you need to tell them that look for warning signs of preterm labor, which include abdominal cramps, a low dull backache, pelvic pressure, increase in vaginal discharge, leaking per vaginum, and uterine contractions. Now that we have understood how to diagnose preterm labor, let's see how we should manage preterm labor. So the management strategies are based on 4 important verticals. First, do we need to allow labor or arrest labor? How do we identify the etiology so that we can initiate appropriate treatment? And we need to ensure that the patient is delivered where NICU care is present so as to get the best outcome for this newborn. Why use tocolytics at all? Obviously, you know tocolytics are the ones which arrest labor. We need to buy time for the steroids to act, for the antibiotics to act, so that the patient is transferred with the fetus in utero to an NICU center, and we can tide over self-limiting causes. So the treatment involves inhibition of labor with tocolytics, corticosteroids to accelerate lung maturities, antibiotics to treat subclinical, latent, and overt infection, and other therapies which can be given to the patient. When do we arrest labor? In other words, when do we use tocolytics? When the mother is normal, the baby is normal, she's not in active labor, the baby is live, tocolytics are not contraindicated, and she is less than 34 weeks by gestation in her pregnancy. Inhibition of labor can be achieved by bed rest, hydration and sedation, and tocolytics. And let's look at each of these in how effective they are and when they should be used. Sorry to say, but most of the efforts to prevent preterm labor are not effective. And I must confess that until effective strategies are found, our efforts should be aimed at preventing neonatal complications by giving these interventions which will have or which have been proven to have an extremely positive effect on neonatal survival and neonatal outcomes. They include steroids, antibiotics, avoiding traumatic deliveries, and delivering in a center with experienced resuscitation teams and NICU care. So these 4 are essential in giving the best to the babies who are born preterm in the present situation. A little bit about hydration. IV hydration, all of you will agree, does not seem to be beneficial even during the period of evaluation or soon after admission. But it does have a small role. And especially in our population and in our climates, which are extremely hot and humid, that the patient may be dehydrated either because of the climate or because of the infection or because of the gastroenteritis, the vomiting, etc. And in these situations, hydration is found to be beneficial. Of course, this is limited to this small subset of patients. Moving on to tocolytics. Just like progesterone, we do often we overuse tocolytics, but I'm sure because tocolytics ensure that few days would be gained, which would be put to good use, such as completing the course of corticosteroids or ensuring there is an in utero transfer. Now, there are three types of regimens for tocolytics. One, tocolytics being used for acute preterm labor, then de-escalating them to maintenance therapy, and thirdly, prophylactic tocolytic therapy. So acute preterm labor would be completely, tocolytics would be initiated with the sole purpose on completing a course of corticosteroids or in utero transfer and reduce the proportion of births occurring within the next 1 week. Maintenance, both oral and parenteral, may be for maintenance therapy beyond the first 48 to 72 hours, and prophylaxis would be for those patients who are at high risk for preterm labor. So acute tocolysis is generally given parenterally for 18 to 48 hours. The risk-benefit ratio for both the mother and the fetus needs to be reevaluated on an ongoing basis, should be used selectively, and never after 33 weeks. The various tocolytics that are available are the beta-mimetics, isosuprene being the commonly used one. You also have atosiban, which is in the market, calcium channel blockers, nifedipine, which is commonly used. We also have indomethacin, magnesium sulfate, and nitroglycerin patch. Different tocolytics act at different levels. Calcium channel blocker is nifedipine. Calcium magnesium channel alteration occurs with magnesium sulfate. Beta-mimetics act via the beta receptors. Atosiban directly acts at the oxytocin receptor, and nitroglycerin acts via the NO donors, affecting the cyclic GMP actin myosin pathway. They are given in different forms, either IV or oral, as an infusion, as a patch, and different therapeutic regimens are available. One must ensure that you monitor the patient who is receiving tocolytics, especially in cases of beta-mimetics. Look at the pulse rate and the blood pressure. In magnesium sulfate, the respiratory rate, the urine output. In indomethacin, fetal echo. In nitroglycerin, pulse and blood pressure. And in nifedipine, blood pressure as well. Because all these can affect the normal hemodynamics and could have adverse fetal outcomes if they are not properly monitored or overdosage is done. Some of the common side effects with beta-mimetics are hyperglycemia, pulmonary edema, hypotension, and tachycardia. And these are the ones in yellow are the ones which are life-threatening, and one must look at them much more carefully and be alerted at their slightest occurrence. Indomethacin has fetal consequences with constriction of ductus and renal failure, and the patient has to undergo ultrasound and 2D echo to look for oligohydramnios and cardiovascular changes in the fetal heart. Magnesium sulfate, as you know, is associated with cardiorespiratory depression and has to be closely monitored as well. Nifedipine, flushing, nausea, commonly occurring as also hypotension, but on a rare occasion, pulmonary edema can occur. And with atosiban, lactation inhibition can be a problem. Also, it can cause uterine inertia and hypotonia, resulting in PPH if the patient finally goes into preterm delivery. Pulmonary edema is one life-threatening complication that we must avoid at all times. And this is known to occur if tocolytics are given in combined regimens, and therefore they should never be given in combined regimens, especially beta-mimetics and nifedipine, magnesium sulfate together. Never do that. Concurrent steroid therapy can worsen it. Prolonged tocolysis, crystalloid infusions when there is a fluid overload, and in patients who have twin pregnancy, chorioamnionitis, or anemia. Ductal constriction, as I told you, occurs with indomethacin and can have fetal effects like cardiac failure and hydrops, and neonatal effects like persistent fetal circulation. And these are the ones which need to be carefully looked into and evaluated on a week-to-week basis. There are certain contraindications for tocolytics, but the ones which are universal are severe preeclampsia, abruption, chorioamnionitis, fetal anomalies, active labor, and IUGR. And you would have specific ones depending upon which group of tocolytic therapy that you're using. This is the checklist for the same. One must ensure that therefore you ask the patient for any associated cardiorespiratory, metabolic, or systemic disease that the patient is having, and then decide on a risk-benefit ratio whether tocolytics would be safe for her. Tocolytics are advantageous, and there is no doubt about it. Beta mimetics, which we use commonly, are effective, cheap, easy to administer, rapidly acting. Nifedipine also has a good side effect profile and also has known to have positive neonatal effects. Atosiban is also found to have safe side effect profile. Magnesium sulfate, besides tocolysis, also causes neuroprotection. More about that later on in the lecture. Indomethacin, ease of administrating, effective, cheap, especially useful in polyhydramnios as it causes a reduction of liquor. And NTG patch, no injections, no tablets. The patch is easy to use, especially when you're doing your uterine in utero transfer. So like I told you, indomethacin useful in polyhydramnios, magnesium sulfate in diabetes, rescue therapy, atosiban with direct action on the oxytocin receptors. But remember, there is no role of prophylaxis or maintenance tocolytic therapy in patients who do not or have not had symptoms of preterm labor. If they have a risk factor, well, yes, prophylaxis would be useful. But in those where there is no risk, just for the sake of giving prophylaxis, no, tocolytics should not be used. Dual tocolytics, no, I have already talked about it. And now we move on to the newer tocolytics and understand a little bit about atosiban and nitric oxide donors. Atosiban is given as an IV infusion. The initial bolus dose is 6.75, and then you have a high dose infusion at a rate of 300 micrograms per minute, followed by a low dose infusion of 100 micrograms per minute. The high dose is given over 3 hours, the low dose is given over 45 hours, and therefore you have 48 hours of infusion therapy with atosiban. The full dose should not be more than 330 mg. It should be started as soon as the diagnosis of preterm labor is certain. Alternative therapy should be considered if there are persistent uterine contractions. And as far as renal and liver insufficiency, no data are available regarding the need for dose adjustments. Common side effects are nausea, headache, dizziness, hot flushes, vomiting, tachycardia, hypotension, injection site reactions, hyperglycemia, and rarely there could be a pruritic rash which can occur. For the fetus, no undesirable side effects have been identified. The skin patch causes endogenous vasodilatation, decreases vascular resistance. It contains 50 mg of nitroglycerine, daily releases 10 mg, so it can be given over 5 days, and the drug release area is about 20 centimeters square. The transdermal route delivery is preferred as it avoids the high first pass inactivation in the liver. Corticosteroids. The two corticosteroids are betamethasone and dexamethasone. Betamethasone 2 doses, 12 milligrams, 24 hours apart. Dexamethasone 6 milligrams given 12 hours apart. At least 4 doses are recommended, but 2 doses are useful. Steroid prophylaxis should be given before 34 weeks. Its optimal effectiveness is between 24 to 7 days. It lessens RDS, NEC, and IVH, and therefore it's a life-saving and life-altering medication for preterm babies. It enhances the response to neonatal surfactant therapy, lessens the incidence of PDA, causes circulatory stability. Even a single dose of 24 mg in divided doses is found to be a life-saving medication in preterm babies. Which is better, betamethasone or dexamethasone? Betamethasone alters the NST and biophysical parameters, but causes less incidence of periventricular leukomalacia. On the other hand, dexamethasone BPP is not affected, but doesn't lessen periventricular leukomalacia. Both are equally effective. In the Indian scenario, dexamethasone is more commonly available, but where available, betamethasone can be given because you just need to give 2 shots, while dexa, more frequent number of shots may be required. Antibiotics. Routine antibiotics are not recommended as per the Oracle 2 study. Treatment of asymptomatic infections should be aggressively treated in cases of asymptomatic bacteriuria. Postpartum endometritis is less, and GBS prophylaxis is recommended. And there are certain safety concerns about clavulanic acid and its preparations with respect to neonatal gut motility and gut affection. But the generally used safe antibiotics in preterm labor are ampicillin, amoxicillin, clavulanic acid, erythromycin, and cephalosporins. Amongst this, if I had to choose one, it would be cephalosporins for acute dosage and erythromycin for maintenance antibiotics. Moving on to delivery in preterm babies. The key principle in carrying out delivery of a preterm baby is atraumatic birth of a well-oxygenated baby. This was first identified by Professor Joseph Dilly, who invented the concept of prophylactic forceps. And he said forceps are not just tools of extraction, but they are tools of protection as well, as they should be employed in preterm birth, as they form a protective cage along protecting or covering the fragile skull in a preterm baby. Epidural analgesia is indicated as it gives good pain relief. Interpretation of the CTG should be it should be kept in mind that the preterm baby may have a different kind of a pattern. Episiotomy not always essential, but I personally give episiotomy because it helps in widening the birth canal and reducing the decompressive forces. Forceps should be used, and at times in LSCS, the DLE's vertical lower segment incision may be useful. Delayed cord clamping has been recommended by WHO in 2006, and it said that delayed cord clamping will result in fewer transfusions in the neonatal period, decreased hypotensive episodes, and less IVH, and should be kept in mind when we conduct preterm deliveries. The preterm baby has got a whole lot of complications, ranging from not just early complications like apnea, birth asphyxia, feeding problems, aspiration, but the key ones are respiratory distress syndrome, nutritional problems leading to NEC, jaundice, electrolyte and temperature abnormalities, and the late ones include cerebral palsy, retinopathy of prematurity, bronchopulmonary dysplasia, failure to thrive, and a lot of problems into adult life because of prematurity. But advances in neonatal care have really changed the picture over the last few decades. We now have surfactants which help in reducing the risk of respiratory distress syndrome, better and advanced ventilatory care, temperature regulation with radiant warmers, early breastfeeding with tropic feeds and human milk fortifiers. And now we are able to screen these babies using the screening techniques like a new neurosonogram, cardiac evaluation, hearing of the babies, and ruling out retinopathy of prematurity by an ophthal examination. And all this helps us to identify the challenges and treat them at the earliest so that the best neonatal outcomes can be achieved in these preterm babies. Of course, that is the part on the behalf of the doctors, but we need to motivate the parents as well, because finally, they are the ones who are going to care for these babies over their childhood. And hence came the concept of kangaroo care, which is based on the principle of skin-to-skin contact. Like the kangaroo pouches its infant, so does the mother or the father, pouching the infant against the parent's breast, bare chest, which is known to improve the bonding between the parent and the newborn. It not only reduces parental stress, but it promotes confidence in caring for these babies. And strangely enough, but proven enough, it also improves infantile and neonatal health. Moving on to magnesium sulfate. Magnesium sulfate has been the wonder drug as far as pre-eclampsia and eclampsia is concerned. But in the present scenario, it has found to be even having one more advantage because it is known to be even effective as a fetal neuroprotector. These are the various studies which have been published across the world, which have now undoubtedly proven the role of magnesium sulfate as a fetal neuroprotector. It should be given in patients with imminent preterm birth before 32 weeks of gestation and should be considered for all of them. It is an evidence 1A level of evidence and therefore is well established. If antenatal magnesium sulfate has been started for neuroprotection, tocolysis should be discontinued and Maxsulf should be discontinued if delivery is no longer imminent or a maximum of 24 hours of therapy has been administered. For women with imminent preterm birth, antenatal magnesium sulfate should be administered as a 4-gram IV dose over half an hour, followed by an infusion of 1 gram infusion until birth. For planned preterm birth or fetal or maternal indications, magnesium should be given 4 hours before birth. It should be started ideally within 4 hours before birth as a 4-gram IV load and followed by 1 gram per hour maintenance infusion until birth. So where you know that you're going to do an elective section or a semi-elective section, start it and give it over 24 hours. Obviously, where you don't have enough time, continue it till the baby's birth. Every little magnesium sulfate that goes to the baby will improve neonatal neurological outcomes in these babies and reduce their risk of cerebral palsy or neuroaffection in childhood and adulthood. When magnesium sulfate is given for fetal neuroprotection, maternity care providers should use existing protocols to monitor women who are receiving magnesium sulfate for pre-eclampsia or eclampsia. So the same monitoring should be carried out, and one knows that magnesium sulfate has its own complications. So look for the urine output, look for the respiratory rate, even though the patient is not pre-eclamptic or eclamptic, but still she could land up with cardiorespiratory compromise. To summarize, then, what is the truth of all these therapies? Prophylactic tocolysis? No. Progesterone therapy? Yes, a role. Injectable? Yes. Vaginal? Yes. Cerclage? You need to use it judiciously. Bed rest may not be useful. Antibiotics? Risk-benefit ratio. Prenatal care required for all. So my take-home messages as I conclude my talk is that, friends, prematurity is the leading cause of neonatal morbidity and mortality. There should be a risk-based approach to screening universally all pregnant women. Those at risk for preterm labor are the ones with history of previous preterm birth, a short cervix, which is assessed on ultrasound, and multiple gestation. Transvaginal ultrasound is now recommended in all pregnancies for cervical length assessment. Appropriate preconceptional and antenatal care will improve maternal condition and reduce the risk of preterm birth. Guidelines across the globe support progesterone treatment for prevention of preterm birth. Most situations clearly show benefit with progesterone therapy, and cervical cerclage has a role in those with a significantly short damaged cervix. Appropriate and timely use of tocolytics, steroids, and antibiotics form the mainstay of therapy in preterm labor. Tocolytics should be chosen after assessing any contraindications and to gain time for pulmonary maturity. Neonatal outcomes clearly show benefits with NICU care, in utero transfer, and steroids and magnesium sulfate therapy. Friends, preterm birth has long-lasting implications on adult life and financial resources and emotional stress. So we should have a three-pronged attack: prevent preterm birth, manage preterm labor, and treat the premature baby with the best of care in the best of facility. And our long-lasting motive should be we must reduce or eliminate preterm birth, and this can be done by thereby ensuring that it will lead to the greater goal of reducing mortality amongst babies born preterm. So like Ban Ki-moon, the UN Secretary General said, let us change the future of millions of babies born too soon for their mothers and families and indeed for the entire country. Enabling infants to survive and thrive is an imperative for building the future we want. We did come with baby Beti Bachao, but I think we need to now also focus on baby Bachao and ensure that babies are not born preterm so that they can be bachawed. Thank you so much, friends, for a patient hearing. Thank you, Nilesh, for giving me this opportunity. I have been very fortunate and motivated to release the checklist on preterm birth at the AICOG 2017 in my capacity as Food and Drug Committee Chairperson, and later bringing in the FOXI guidelines on preterm birth and preterm delivery and the role of tocolytics under Dr. Nandita Palshitkar's presidency, where I was the Joint Secretary when we had the conclave in Kochi in February 2019. Thank you once again, friends. Sorry for the exhaustive talk, but I was told by the organizers that I need to cover the entire aspect of preterm and preterm birth.
Thank you, sir. It was a wonderful talk, and I think many of the points were so new and so updated that it indeed gave a good scenario about the preterm labor. And I think always good conversations with right people are priceless, and this is one of those which all must have witnessed here. So thank you for that wonderful presentation. I took some more take-home points from your lecture, and few of these points were the 24 by 24 rule, which I would take home, the 50 by 50 rule, transvaginal cervical scan, a must and a newer thing for everybody between 19 to 24 weeks. Prophylactic cervical cerclage is judicial use is as important as the use of injectable progesterone and transvaginal progesterone. 17-hydroxyprogesterone versus micronized progesterone, we have positives and negatives, but both are validated. And one important sentence from all of your talk was a traumatic birth of a well-oxygenated baby. I think it's so wonderful to give that take-home message. And as we said, the prophylactic forceps application by DD, you also highlighted the history about this. So wonderful in all senses. It was a wonderful lecture. Thank you so much. We will take all the questions, sir, for you from all the delegates. But before that, we have an interesting quiz based on sir's lecture today. I think most of the questions from the quiz sir has already answered in his talk. It's just you have to answer and win prizes for yourself. So all the delegates who have participated, we have this interesting quiz which is being set now. Sandeep and support team, can we just have the quiz questions? Yeah. So I bring greetings from the FOXI quiz committee, and can I have the first question for the delegates? Yeah. So your first question is, to prevent preterm labor in women with heart disease, following is the first line of management: A, ritodrin, B, duodenum, C, atosiban, and D, salbutamol. So your time starts now. Those who answers it correctly and answers it in quick time, those will be selected as the winners, and answering all the 5 questions is very much important. So please answer this question in the poll section in front of you. Sandeep, any special instruction for answering?
No, sir. They can select the options from the poll.
Okay, so you can select the options from your poll and just tell Sandeep when the time is over.
So you can allow for 30 seconds and then we can move ahead.
Yeah. Can we have the poll, what people have answered, and after that we'll have the right answer. Sandeep, can we have the poll, please? we can stop the...
Sir, can we finish all the questions in a line and then we can exhibit the poll?
Okay.
Yeah.
So second question, please.
Yeah.
Yeah. So the intervention which is effective in management of twin pregnancy in reducing preterm birth is A, bed rest and hospitalization, B, prophylactic cerclage, C, progesterone therapy, or D, transvaginal monitoring of cervical length. Your time starts now. So I think Sir has already stressed on each of these aspects, and we are well aware of the fact to be used in twin pregnancy. So you can answer this question in the poll section of your screen. Last 5 seconds. Thank you. Sandeep, we can close this question and go on to the third question. Yeah. Can we click once again? Yeah. So you have to identify this SIN, and the identification is there. It is a transvaginal sonography of the cervix with funneling and bulging of the amniotic sac. So the question is, what is the risk of recurrent preterm birth if cervical length is less than 25 millimeter and also the fetal fibronectin is positive? So both of these are positive. The cervical length is less than 25 and fetal fibronectin is positive. The chances of recurrent preterm birth are, is it A, 20%, B, 35%, C, 65%, or D, 90%? Your time starts. Last 5 seconds. Thank you. Can we go on to the fourth question, please? Yeah. Following drug can help in neuromaturity of a preterm baby. A, magnesium sulfate, B, dexamethasone, C, betamethasone, D, atosiban. So your time starts now. I also thank the FOXI office bearers, Alpesh Gandhi sir and Dr. Jaideep Tank, Secretary General of FOXI, for this unique initiative of Core Connect. And this month we have the Prematurity Awareness Month, and the hashtag born too soon is being floating around in the social media. So please log in for the FOXI conference also. So I think the time is up for this question. Can we move on to the next question, please? The last question is, early delivery can cause adverse nutrition in early life, including prenatally, as measured by the birth weight, increased susceptibility to metabolic syndrome, which includes obesity, diabetes, insulin sensitivity, hypertension, and hyperlipidemia, along with complications of coronary artery disease. All this is called as Iron-Donald's theory, Barker's hypothesis, Ballantyne's theory, or Sims hypothesis. So early delivery, early in life, causing adverse reactions in adverse complications in early life can later on lead to other metabolic complications in the form of obesity, diabetes, hypertension, and so on, the syndrome X. So what all is said is being said by which theory or which hypothesis? A, B, C, or D? Last 5 seconds. Thank you. So I think my quiz is done. Can we have the poll, please?
Yes, sir. Just a second.
Sandeep, if it's taking time. Okay. Yeah, thank you. So the answer given to the first question is by many of us is in heart disease, which can be used as a topolytic. Many have answered as atosiban or salbutamol. I think the correct answer is atosiban, and many of the people have answered it correctly. Can we go on to the second question? Yeah, intervention which is effective in management of twin pregnancy in reducing preterm birth. Many have said it as progesterone therapy and transvaginal monitoring of cervical length. The correct answer here is transvaginal monitoring of cervical length. The third question, please. Yeah. So what is the risk of recurrent preterm birth if cervical length is less than 25 millimeter and fetal fibronectin is positive? Many of the delegates have answered it B or C, that is 35% or 65%, and the correct answer is C, 65%. The fourth question, please. So which of these following drugs? So I think all 100% have given it correctly. I think, sir, everybody has listened to you. Neuromaturity is helped by magnesium sulfate. It has got a very huge role. So last question, please. Yeah. So early delivery can cause adverse effects in the later on of life, and this is called as the adult onset of fetal disease, and this is called as the Barker's hypothesis, which is option B. So I have all the options given, and at the end of sir's question and answer, so we'll have the audience questions to sir now. After the end of this, we'll announce the winners for this quiz, who will get the interesting prizes of a trolley bag for the first 3 winners. Sir, a question to you is, which steroid do you recommend at 34 weeks, and what is your choice about the steroid and the dose? Sir, kindly unmute yourself.
So it really doesn't make a difference whether you are using dexamethasone or betamethasone. Both have got equal efficacy. Now, why is there a debate? Remember, where betamethasone is available, use betamethasone because the number of doses are less. Because it has to be a medically administered medication. But dexamethasone is more readily available even in the public sector, more so in the public sector. Its potency is found to be more tested and more certified as far as the low resource countries are concerned as compared to betamethasone. And so therefore, it is more widely.
Anything related to the salt? Many of us have heard that the salt available in India is a little bit different.
WHO came up with the statement saying that the salt at times of betamethasone may be slightly different, and therefore dexamethasone has been certified. But if betamethasone is commercially available, it can be used. Both have equal efficacy. There is no question.
Okay. So
personally, I use betamethasone as compared to dexamethasone.
All right, sir. Thank you so much. Sir, I would like to tell you that for your talk, more than 525 delegates logged on Facebook Live, and around 800 people logged on in our Zoom portal. So it was a wonderful session, I feel.
I think it was mainly because of the trolley bags rather than my injections.
No. Wonderful, sir. It was a wonderful talk over and all and all. Sandeep, do we have any other questions? Can you share it on the chat box, please?
Nilesh, 2 things I want to tell you.
Yes, sir.
One, that in the quiz, okay, we should avoid taking any pharmaceutical brand names. So Duadilan is a pharmaceutical brand name. We should use isosuxprine in the questions. And number 2, you talked about the various take-home messages. So there was one take-home message which I forgot to say, and that is about the cervical change that occurs. These are called as IAMS criteria. I talked about TYVU in a progressive manner. So the simple way to remember it is trust your vaginal ultrasound.
Right, sir. Right, sir. So I think a good vaginal ultrasound is very much necessary, and
it begins with T and it ends with U. TYVU. So trust your vaginal ultrasound.
Yeah, yeah, yes, sir. TVYU. TYVU. Yeah. So next question to you is, can labetalol be used in preterm labor? Any experience from your side?
No experience, because it has got a more slower onset of action and doesn't act via the uterine musculature.
Right. So in your tenure as Joint Secretary of FOXI, you have come up with a checklist of preterm labor. The question is, where can we get the checklist of preterm labor? I think it's available on FOXI website. You can put a light on this.
Yeah, it is available.
Yes.
Or they should get in touch with Dr. Pratik Tambe, okay, who was the endocrinology chairperson. He would be able to hand over the copy of the same.
Okay. So we have seen about tertiary care centers where preterm labor is managed. Any change while managing it in tier 2 cities or in small towns? Can you put a light on this? Any change we can make regarding the NICU facilities? What all care should be taken?
So as far as possible, just like we transfer our maternal patients into a HDU when we know that maternal life is at compromise or at risk, okay, and requires more critical care. Similarly, we must transfer these patients to facilities where NICU is available, where a neonatologist is there. Now, where we have a compromise or there is a restriction on resources, in that case, you must make a neonatologist or a pediatrician available at the time of delivery and then transfer the baby immediately after initial resuscitation to a facility where the baby can be closely monitored. Now, there may be a circumstance where none of this is possible, and therefore every obstetrician should have the basic knowledge of neonatal resuscitation and conduct the delivery in the most atraumatic manner so as to reduce the insult on the baby. So these are the various things, and ensure that no baby is born without getting the steroid if it is going to be a preterm baby.
Yes, sir. And you also recommend magnesium sulfate also, those who are having...
Magnesium sulfate again requires proper monitoring. So where it is proper, it can be properly closely monitored, you must give it, or you move into a facility where you have adequate nursing staff, you have adequate backup, where it can be closely monitored.
Sir, can you put a light on the dosage of magnesium sulfate and the duration? If the delivery is not imminent in 24 hours, do we repeat it?
No, we don't repeat it. We give 4 grams IV bolus, followed by 1 gram IV bolus over half an hour, followed by 1 gram per hour over 24 hours. We don't repeat beyond.
Okay, sir. Thank you.
And never to give it beyond 32 weeks. It's found to be not less than 32 weeks.
Yeah. My question to you is, sir, what is the cutoff you consider for so that the baby will not have any neurological problems? Like as early as what gestational age do you find? How will you counsel the couple regarding the future course of these babies born extremely premature babies? Like, is it 26 weeks? Is it 28 weeks? Or sometimes even with good NICU facilities as early as 25 weeks. Like we have all these VIP babies of IVF patients. Those who have other problems, like they are elderly, they are having twin pregnancies, and they have more chance to end up in preterm birth. So what is your cutoff and how do you counsel these patients?
Okay. So here you have to be very clear in what you talk to the patients. Your role as the obstetrician is to ensure, one, try to prolong the pregnancy as much as you can. If you can't prolong the pregnancy, ensure that the baby is born with least trauma and in a center where the baby can be immediately shifted into NICU care. Who is going to give you the prognosis as far as NICU care is concerned is the neonatologist and his team. So let him do the talking or her do the talking, because they are going to accurately tell you what the fetal or the neonatal newborn response is to the various accommodations that are going to occur once the baby is born. You are not a specialist in that. all you can tell is that there is a challenge. Okay, the best chance of survival is beyond 34 weeks. Fair chance of survival is beyond 30 weeks. Substantial chance of survival may be between 28 to 30 weeks if baby is born in NICU care, but it would be the NICU person who would give you the chance of survival or the prognosis depending upon when the baby is born. It is not your decision. You must not take that decision yourself. As far as the second point is concerned, like you said, in IVF pregnancies, there may be a time where you may have to deliver early. There may be multiple pregnancies, etc., between 24 to 28 weeks.
Yeah.
You need to tell them that prematurity is a common complication in these pregnancies. You have to take it in the stride. With advances now, it is possible that these babies will survive and have good outcomes. And that's why they need to go into a center where there is NICU care. Also, you need to emphasize to them that there is high amount of financial liabilities in this care because it's critical care. Okay. And therefore, they must also ensure that adequate financial resources are accumulated and available when these babies period of time. Because if you have a 22 weeks baby, they are going to be in NICU for almost 2.5 months.
Absolutely.
So all that has to be talked to the patient. So as an obstetrician, your role is that from intervention, try to prevent, try to prolong, and if you can't, ensure that you deliver the baby in the best possible way, in the best possible environment. And as far as baby's outcome is concerned, you can tell them that it will be all decided once the baby is born. There are challenges and complications. You have to take everything as it comes, one after the other. There is no doubt about it.
Thank you. So one straight question to you, sir. For these extremely preterm babies, like nearing 26 weeks, 28 weeks, you said about safe delivery and appropriate care during the time of delivery, a traumatic birth, cesarean section or labor, vaginal delivery?
I think cesarean section, there is no question about it, because unless the patient comes fully dilated or there is head-on perineum, etc., I would like to tell you two instances where I have given up on the baby. Okay, one was a case of cord prolapse with PROM, and I thought the baby will die. The baby is surviving now, 3 years old, in better health than you and me. Okay, with all milestones. Okay. Again, it was an IVF pregnancy. We call that baby fondly Mrutyunjay. Okay. Wow. Because I think nobody expected it to survive, but it just survived. Possibly because the patient had undergone cerclage, emergency cerclage, and then she was put on complete bed rest, and the baby had that stress in utero and developed all the accelerated lung maturity. I don't know. It's God's grace. The second case was a case of breech presentation. Patient went for Sachin Tendulkar's last farewell match at Wankhede Stadium, started leaking. Okay, came from the Wankhede Stadium to the hospital, which is close by, was breech. Again, we could prolong for a period of time, I think about 7 days or so. Given up on the baby, 23, 24 weeks, breech presentation. Went into active labor undetected. When we did the PV, the breech was on perineum. Baby delivered. The NICU was exactly 10 meters away from the birthing suite. As soon as baby was born, surfactant was given to the baby. Baby survived after 2 months of NICU care, also doing well. Okay, playing good cricket like the Master Blast. So in these circumstances, you will have to, but 98% of the times, I would go ahead and do a cesarean section, because that would be the safest for the baby in those circumstances.
Right.
Of course, you need to weigh the consequences. You have to ensure that, like all cesareans, you will have to take the consent, explain the risks, and ensure that the checklist is fully satisfied. And baby delivery can be at times challenging, and therefore you may have to alter your approach of incision and delivery.
Right, sir. So what is your choice of progesterone for preterm labor? That is a question from audience.
If it is a prophylactic progesterone, then the vaginal progesterone is fine. If it is in therapeutic progesterone, injectable progesterone, because not only are you monitoring the patients, you are also giving the progesterone therapy at the same result.
Any role of L-arginine in preterm labor?
Not in preterm labor, but in oligohydramnios and growth restricted babies, it does have a role.
Okay. Any other empirical strategy for preterm labor, like bed rest or head low, anything will help?
Every empirical strategy, as long as it's not causing harm, can be employed. But you must remember, in your patients, who have IVF pregnancies, have comorbidities, etc., too much of bed rest is also not good. It increases the risk for embolism. So these patients require proper anti-thrombotic prophylaxis.
Yes, sir. I think an important point being brought out at the end also. So that's about the questions, sir. We have the winner list for this quiz, which is given in the chat box. That is Dr. Geeta Sari Poddar from Mumbai, Dr. Ketan Parikh from Ahmedabad, and Dr. S.J. Patel from Jharsuguda. So these are the winners for today's quiz, sir. And I thank you personally for giving me the opportunity to interact with you and moderate your session. It was indeed an honor for me. And I personally found some take-home messages from your talk, which I'll implement in my practice. Thank you so much. Any few words, last words from you, sir? Amey, sir.
Yeah, so first of all, congratulations to the winners. When it's Nilesh forming the questions, they are they are highly academic and quite difficult at times. So you coming out of winners out of those, I mean, it's really commendable. Nilesh, congratulations on the quiz. I'm seeing a bright future for the quiz committee. I was an integral part of the quiz committee when Ashwath was the chairperson.
Yes,
and because I had to take another role in Foxy, so that's why I didn't pursue my dream to become the quiz committee chairperson. But anyway, what happens for the good, I believe. So the quiz committee is something which is always near and dear to my heart, and I do observe the proceedings of the quiz committee very closely. Secondly, I would also like to thank the Foxy leadership for initiating this and ensuring that knowledge is disseminated, and knowledge which will be practically beneficial. And also to Corona Remedies for taking up this platform and ensuring that this is done on a regular basis, so that the continuity of knowledge and the continuity of experience is handed over from practitioner to practitioner. And last but not the least, like you said, it is the Prematurity Awareness Month. So we must have the hashtag of Baby Bachao and ensure that prematurity rate, not just maternal mortality rate is 0, but prematurity rate is 0, so that we won't have any baby dying because of prematurity.
Yeah. Thank you, sir. Thank you, Corona Remedies. Jaiswal, sir, comments from you. Thank you.
Yeah, it's now the time for the vote of thanks. So on behalf of Corona Remedies, I thank Dr. Ame Gurandare for his insightful talk, as well as Dr. Nilesh for moderating the session. I also thank all the delegates who participated in this knowledge enhancing activity and make it successful. And thank you all once again, and wishing you all a very happy and safe Diwali in advance. Thank you.
Thank you.
Happy Diwali to everybody, and stay safe, stay happy. Don't burst crackers at all. We need a healthy, pollution-free environment so that we can overcome the disease quickly.
Happy Diwali, sir, and happy Diwali to everyone. Thank you.
Thank you, sir. Thank you, sir. We are closing, sir.